Hi, I'm Ralph Preston, and here we are again on Tuesday morning having another Stroke Buddies Stroke Survivor Support Group meeting. And let's see, this week we've got Dr. Bruce Hetzler. He's making presentation number 5. I know I've enjoyed the other 4 and gotten a lot out of them, and I'm sure I will with this one, which is on stroke and sleep. And obviously, sleep is a very important thing anytime, but I guess it becomes even more important post-stroke. So, Dr. Hetzler, why don't you share your PowerPoint with us and take it away?
Well, thank you. I will do that, Ralph. Stroke and sleep. Try not to go to sleep. Here we go. Here's what I'll cover. The stages of sleep. REM sleep, that stands for rapid eye movement, and NREM or non-REM. That's the other stages. Now, to determine what stage of sleep you're in, we need to record 3 parts of the body. EMG, electromyogram, that's muscle tone. EOG, that's electrooculogram, that's eye movement, and EEG, or electroencephalogram, that's brain waves. Then we'll ask, why do we sleep? And then talk about types of insomnia. And then dysomnias, those are disorders, and parasomnias, those are disorders. Then we go to hypersomnia after stroke, that is excessive sleeping after stroke, and then other sleep problems after stroke. So we'll start by mentioning that to record stages of sleep, we need the electromyogram. That's an electrical potential recorded from an electrode placed on or in muscle. For sleep studies, it's typically attached to your chin. That records the muscle tone. Electrooculogram, that's an electrical potential that records eye movements. And that's typically recorded from electrodes attached next to your eyes. And this shows brain waves and how they change from wakefulness to the stages of sleep. So if you look at the top of this figure, if you're awake and alert, you have what are called beta waves. These are high frequency, small brain waves. When you're awake, alert, paying attention, which hopefully you're all doing now. Now, if you close your eyes and aren't thinking of anything, then you have alpha waves. And they're slower and larger. When you go into sleep, you have slower waves still. These are called theta waves. And these occur during the initial stage 1 of sleep. You then go into stage 2, where you get what are called sleep spindles, and they're sort of like alpha waves and what are called K complexes. It's a big up and down pattern. Then you go into stage 3, where delta waves begin to appear. These are these large, slow waves you can see in the pattern. Then in stage 4, the deepest stage of sleep, you have almost entirely delta waves. So delta is ready when you are. And to record all this, you need all these wires. Doesn't that look comfortable?
Mm-hmm.
Yeah, I've had 3 sleep studies. So you get all these wires, all these electrodes taped to your scalp and face and so on, and they're attached to a ponytail at the back of your head. I guess it's a little different than Ralph's ponytail when he has long hair. But then the ponytail wires are plugged into a console behind you on the wall. And if you have to get up to go to the bathroom, you have to push a button, and a nurse comes in and pulls them all out of the wall, and you go into the bathroom with all these wires hanging off your arm, and try not to drop them in the toilet.
An apt description.
So this shows a typical night of sleep. You've got 8 hours, which you should all be getting. And if you look at the far left, the W stands for wakefulness, and then you see stages 1, 2, 3, and 4. So initially, you start being awake, then you go to stage 1, then 2, then 3, then 4. And you're in stage 4 for a while, then you rapidly go up to stage 1. But every stage 1, after this first one, is when you have REM sleep, that is rapid eye movement sleep. And that's when you do most of your dreaming. And as you can hopefully see, REM stages occur at roughly 90-minute intervals throughout the night. You have about 5 REM stages, and you typically awaken during the last REM stage. You may also notice that the REM stages get longer and longer over the course of the night. The first one may be about 10 minutes long. The one you awaken from in the morning could be an hour and a half long. And that's the one you typically awaken from, and that's the dream you typically remember, the one you awaken from. You've had these other 4 dreams, but you have no memory of them. Now, you'll also notice that the deeper stages of sleep drop out over the course of the night. So early on in the night, you go down to stage 4, then back to REM, and then you're in stage 4, but not as long, and then it vanishes, and you're just alternating between REM and stage 3. Stage 3 gets shorter, then it drops out, and finally you're just going between REM sleep and stage 2. These deeper stages drop out over the course of the night, while REM sleep gets longer. Is that all clear? Got to remember this because there'll be a test at the end.
Oh, yeah.
Okay. Now, first I'll talk about non-REM sleep. That's stages 2, 3, and 4. And that makes up most of your sleeping time. It's not a mental void. It's not like some black hole that you are in. It's more like thinking, less like dreaming. If you're awakened from this, you will often say that you weren't asleep. You don't think you're asleep. The thought process resembles non-directed thought. It's been called quiet sleep because you typically have slow, regular breathing. However, you're also snoring. So your bed partner is not quiet. You may have somnambulism, meaning you might walk around. Enuresis, hopefully you don't do that anymore. That's bedwetting. Child will do this. If you talk in your sleep, it's during non-REM sleep, and you might have night terrors. I'll return to those, especially during the first stage 4 of the night. These are most often seen in children, and I will return to that. Non-NREM sleep, the more delta waves you have, the more difficult it is to awaken you. Therefore, that first stage 4 is the deepest stage, and when awakened, the person is confused and groggy. The brain seems to be resting. In REM sleep, so-called active sleep, there's an increase in blood flow to the brain and an increase in oxygen consumption. This is called paradoxical sleep. Ralph, you know what a paradox is?
Oh yeah.
That's two doctors standing side by side.
Yeah, I knew that'd be your definition.
Right. Okay. The cerebral cortex seems to be alert because you have beta waves during REM sleep, and that was the brainwave pattern when you're normally awake and alert and paying attention, which hopefully most of you are. It's more difficult to awaken you during REM sleep than stage 4, except by meaningful stimuli. For example, if you have an infant and the baby cries, that will easily awaken you during REM sleep. When you're awakened during REM sleep, you seem alert and attentive. This shows the change in sleep patterns over the course of the lifespan. So when you're a newborn, stages or days 1 through 15, you spend about half the time in REM sleep and half the time in non-REM sleep. As you get older, you'll notice there is a decrease in time spent in REM sleep. That drops off. REM sleep is important for brain development, and your brain is doing a lot of developing during these first few months, but that drops off then. Now, why do we sleep? Well, we talk about the functions of slow wave sleep. That's stages 2, 3, and 4. This sleep is essential for survival. The brain is cleaned, quite literally. You have an increase in cerebrospinal fluid washing your brain. And we'll talk about that in more detail shortly. REM sleep promotes brain development, as I mentioned. It also helps learning. And you may have REM rebound. That is, if you're deprived of REM sleep, you make up for it later. That is, you need to have REM sleep. Now, I haven't mentioned it yet, but when you're in REM sleep, your body is paralyzed. So you can't act out your dreams. And that created a way of depriving rats of REM sleep. You could have them balance on a little piece of wood in a pool of water, and they can fall asleep while standing on that piece of wood. But when they enter REM sleep, they lose muscle tone, fall in the water. Well, that wakes them up. They climb back up on the little piece of wood. You can selectively deprive them of REM sleep. When later given a chance to sleep normally, they have more REM sleep than they would normally. That's called REM rebound. Now I should talk a bit about declarative versus non-declarative memories. Declarative memories are memories that you're consciously aware of, that you can talk about. Non-declarative memories, you may not be able to say something about. You demonstrate them by doing something. For example, if I asked you if you knew how to ride a bike, your answer of yes or no would be a declarative memory. Getting on that bike and riding it would be a non-declarative memory. So REM sleep facilitates the storage or consolidation of non-declarative memories. If you're learning a new motor skill, you remember that better in REM sleep. On the other hand, non-REM sleep or NREM sleep facilitates the storage of declarative memories. That's things you can state verbally. Okay? Sleep, the ultimate brainwasher. Recent research suggests that sleep's basic purpose is to clear the brain of toxic metabolic products. There are fluid-filled channels in the brain that expand during sleep. These are gaps between cells in the brain. And those gaps are full of cerebrospinal fluid, and they get larger during sleep. And so cerebrospinal fluid, in effect, washes the neurons and supporting cells, astrocytes and oligodendrocytes that are in your brain. And this is especially true during non-REM stages 3 and 4. That's when your brain gets a good washing. This is demonstrated in a study published in 2017 by Bendlin. And her research shows that how much sleep you get could affect your likelihood of developing Alzheimer's disease. What she did was examine 101 people, all with normal thinking and memory skills, but thought to have a risk for developing Alzheimer's disease, for example, because a close relative had Alzheimer's. These people responded to survey questions about sleep quality and also let them get a spinal tap of cerebrospinal fluid. You with me so far?
Mm-hmm.
Okay. Those with worse sleep quality and had daytime sleepiness and more sleep problems were also the ones with more biological markers for Alzheimer's disease in their cerebrospinal fluid. They had more amyloid beta protein. That makes up the amyloid plaques that are one marker of Alzheimer's disease. They also had more tau protein. Tau protein is responsible for neurofibrillary tangles in Alzheimer's disease. This is an intracellular problem. That is, normally in the neurons in your brain, you have neurofilaments. These are tubes that go up and down the axon. They're like highways that allow proteins to go up and down, from the cell body to the axon end feet, and from the axon end feet back to the cell body. You can think of them as like uncooked spaghetti noodles, going up and down the length of the axon. But in Alzheimer's disease, tau protein, which makes up the walls of these neurofilaments, it's called hyperphosphorylated. It has more phosphorus groups attached to it, and that causes it to clump up. And these neurofilaments look more like cooked spaghetti noodles, just a clump of things that proteins can no longer march up and down on. So people with bad sleep quality have more tau protein and amyloid beta protein in their cerebrospinal fluid, making it much more likely that they will develop Alzheimer's disease. So sleep well, especially deep sleep. Now, talk about insomnia. There are a number of different types of insomnia. And this shows the percentage of people who are insomniacs that have these different types. So 10% of people have what's called pseudo-insomnia. They think they're not sleeping. But it turns out, if they spend a night in the sleep laboratory, they do sleep. And when asked in the morning, they say they weren't sleeping, but the sleep record shows that they were. When asked what they were dreaming, turns out they dream that they're lying in bed awake trying to sleep. So showing them their sleep record shows them that they were sleeping, and that typically is all that's needed to get them to except the fact that they're sleeping and they're dreaming. Nocturnal myoclonus, 30% of the people, that's restless leg syndrome. That's when you may inadvertently kick your bed partner and you don't want to be the recipient of that. Then there's psychophysiological insomnia, which affects 15%. These people worry about sleeping. They worry that they're not going to sleep. And that worry makes them not sleep. So the worry interferes with their sleep. Psychopathological insomnia, which affects 35%, is insomnia caused by a clinical condition like anxiety or depression. If you can successfully treat the psychopathology, like the depression or anxiety, then they sleep well. And finally, there's drug-induced insomnia. The drugs that are prescribed by physicians to help you sleep can produce insomnia. And that's not so much true anymore. Physicians used to prescribe barbiturates or benzodiazepines, and they produced poor sleep and were addictive. Now they're using antidepressants. If you get an over-the-counter drug, you typically get an antihistamine. And a side effect of an antihistamine is drowsiness. Then there are dysomnias. These cause trouble falling asleep or staying asleep. The best known is sleep apnea. And I'll say more about sleep apnea later, but basically, people with sleep apnea can't sleep and breathe at the same time. When they fall asleep, they stop breathing. Narcolepsy, that's a genetic disorder. And I already mentioned that people fall asleep very easily with narcolepsy. Another symptom of narcolepsy is cataplexy, in which they will fall to the ground, paralyzed but wide awake. It's the REM sleep paralysis that intrudes into wakefulness. The cataplexy occurs if they are caught off guard. For example, if someone throws a football to them or a frisbee, that might produce the cataplexy. Cataplexy also occurs in emotional situations, like if they're spanking a child, or if they're in the middle of sexual activity, they may develop cataplexy and fall to the floor, which is a rather awkward time, lose all body control. Okay, sleep apnea. Stroke patients will often have sleep apnea. I had sleep apnea before I had a stroke, and I still have it. But sleep apnea is not a single disorder. There are three types: obstructive, central, and complex. Obstructive is the most common. The throat collapses when you're asleep, blocking airflow. This affects all ages and both sexes. It's made worse by alcohol. It's typically treated with the so-called CPAP machine. It provides continuous positive air pressure, and you have a face mask. And this is frequently seen in stroke patients. There are also so-called parasomnias. These are disruptive sleep-related disorders. One is REM sleep behavior disorder. And this one, basically, the paralysis that typically accompanies REM sleep does not occur. And what does that mean? That means you can act out your dreams. Is that good? No. This is most often seen in men over the age of 50. And it can occur following a stroke in the brainstem, or it often accompanies Parkinson's disease and some forms of dementia. There was one case of a man in his 50s who had REM sleep behavior disorder, and one night he dreamt he was playing football, and he dreamt he was a linebacker, and he dreamt he was going to tackle a running back. Well, what he did was get out of bed and ran across the room into his dresser. Then there's sleep-related eating disorder. Well, that's pretty obvious. When you fall asleep, you eat. Then there's the night terror, or pavor nocturnus. This is most often seen in children. Young children, say around the age of 4 or 5, they will all of a sudden sit up in bed and start screaming. Their eyes will be wide open, but actually they're in the first stage 4 of sleep. So they are sound asleep, they're unconsolable,
Wow.
they are asleep. So they pay no attention to anything you say or do. Once they move out of that first stage 4, they stop screaming and lay down, and typically everything is fine. And children typically outgrow this. Then there's incubus. This is seen in adults and is the feeling of pressure on your chest while you're asleep, accompanied by the feeling that you are awake. This is probably what was first meant by the term nightmare, or noctmar, or pressing devil. A devil seated on your chest, making it difficult to breathe. And then there's a terrifying dream that occurs during REM sleep, and it's basically a dream that frightens you. Like you're being chased or attacked. And actually, being chased or attacked is the most common dream theme in college students. Okay, this again mentions REM sleep behavior disorder, which the person does not become paralyzed during REM sleep and can act out the dreams. This is an image of an incubus. Okay, sitting on a person's chest. Well, this is a person awaking from sleep but still feeling tired. That's hypersomnia after stroke. Excessive sleeping after stroke can raise concern for both the survivor and their loved ones. But sleeping allows the body to rest and the brain to heal. So it is important with this hypersomnia after a stroke. It helps your brain heal. Unfortunately, I did not get that immediately after my stroke. I was sleeping in the intensive care unit at the hospital, and for some odd reason, the intensive care unit was right next to the helicopter landing pad. So as soon as I'd fall asleep, the helicopter would either take off or land. And that was pretty darn loud. So, of course, that would wake me up. I did not appreciate that. Now, your brain typically uses about 20% of your total energy, and this percentage increases as your brain tries to heal itself. So, getting sufficient rest is normal and important to heal. There are many other benefits of getting adequate sleep. For instance, studies state that quality sleep helps with learning and remembering how to perform physical tasks and that you're trying to do after stroke. You're typically trying to regain tasks that you lost. Sleep also helps boost alertness and strengthen cognitive functions. So, can you get too much sleep?
Recording in progress.
No, you can't. Generally speaking, stroke survivors should listen to their bodies and sleep when they want and as much as they want, because a healing brain requires rest. However, too much daytime sleeping interferes with nighttime sleep. You may benefit from limiting the duration of your naps. You could set an alarm clock to wake you up after 30 minutes of daytime sleep. Some of the more common effects of a stroke include motor difficulties, such as hemiparesis or weakness on one side of the body. When the brain cannot communicate with the affected muscles efficiently, then it takes more energy to complete daily tasks. So you use up your energy more after a stroke. For example, some survivors may find themselves taking longer to get up, brush their teeth, and get dressed. These activities can take up enough energy that you have a desire to nap, and this is normal. Increased energy expenditure caused by normal daily activities is one of the most common causes of excessive sleepiness after brain injury. But there are other factors too, like the location of the injury and other secondary effects. When sustaining an injury to areas of the brain involved with sleep and wakefulness, such as the brainstem and hypothalamus, sleeping disorders can occur. Sometimes there are contributing factors that play a role also, such as depression. Depression is a common secondary effect of stroke. The symptoms may include excessive drowsiness or sleeping a lot. So when survivors show signs of post-stroke hypersomnia, doctors may check to see if there's depression as the underlying cause and prescribe antidepressants or psychotherapy. Sleep problems are highly prevalent following both ischemic and hemorrhagic stroke, affecting up to 78% of stroke patients. These problems include insomnia and sleep-related breathing disturbances. Sleep-related breathing disturbances, such as obstructive sleep apnea, are the most prevalent sleep disorders following stroke, and some form of sleep apnea may be present in as many as 50 to 70% of stroke survivors. I've already talked about sleep apnea because you just stop sleeping, to stop breathing. Survivors of sleep apnea may experience headaches in the morning, or fatigue, or mood swings. Multiple direct and indirect mechanisms may underlie stroke-related sleep disorders, including changes in endogenous circadian control of sleep-wake functions, medication-dependent influences. You're probably all on some sort of medication. I take 5 prescriptions. That's down from, I think, the 9 I had initially after my stroke. But these medications can cause sleep disturbances as well. While sleep-related problems are commonly reported during the acute phase of stroke, there's also increasing evidence for disordered sleep-wake patterns in later, more chronic stages. A cross-sectional sample of patients assessed 1 to 15 years following their first ever stroke found that self-reported sleep quality was relatively consistent regardless of time since stroke, but daytime sleepiness worsened with advanced time since the stroke. The further you're out from the stroke, the more tired you get during the day. Of course, remember, you're also getting older, which may contribute to that. So I'm 11 years older now than I was when I had a stroke. And if you normally get older, which people normally do unless they die, you're going to get more tired during the day. Sleep-like disturbances after stroke have in turn been linked with significant cognitive and attentional deficits, as well as adverse health and clinical outcomes. So get as much sleep as you can. We're dealing with insomnia. Stroke patients should try to remain in quiet rooms at night. A quiet, somewhat cool environment is best. If you need therapy, cognitive behavioral therapy is the way to go. You want to try to avoid medications to help you sleep, but see a psychologist, a psychiatrist that is an expert in cognitive behavioral therapy. That is the end of my talk for today. I hope you'll sleep on it and take away what you need.
What happens when you, to that chart of the REM sleep and 43222, when you get up in the middle of the night to go to the bathroom? Would you come right back where you were? Or I, for one, have very little trouble getting back to sleep. I know some people have a lot of trouble getting back to sleep, so I'm wondering what the difference is. I'm feeling blessed that I basically come back, lay down, and I'm asleep again.
Well, now that was an idealized chart that I showed you.
Right.
A normal chart would include sleep disturbances, getting up to go to the bathroom. As I mentioned, when you spend a night in a sleep lab, which I've done 3 times, I'd have to push a button, which as it turned out, woke my wife, who was sleeping in another room, and she came in and helped me go to the bathroom. You typically just continue where you were in that chart.
Okay.
It is common to have some sort of sleep disturbance. That was an idealized chart.
Yeah, I try and avoid any light when I wake up. I keep the room dark, and um, my bathroom's right off of my bed, so I can actually kind of feel my way over there. I try not to even open my eyes hardly, because I find that if I, particularly in the morning, if it's starting to get light and I see too much light, that's it for sleep.
Yeah, light is a Zeitgeber. It resets your sleep cycle, so you want to try to avoid light at night, and in the morning you'll sleep longer if you don't have light entering the room.
Well, I've always been a morning person, so light means get up and get at it.
Right. Now, different people naturally require different lengths of sleep. There are what are called short sleepers and long sleepers.
Hmm.
Short sleepers typically need 6 or fewer hours of sleep a night, while long sleepers will often require 9 or more hours. And so it helps if your bed partner is the same thing you are, that is a short or a long sleeper. Unfortunately, I am a short sleeper and my wife is a long sleeper. So
Be
that does
quiet.
create some friction.
Be quiet when you get up.
I try.
Go to another part of the house.
Yeah.
Interesting, because when I had my business, I typically slept, go to bed about 11, get up about 4:30. So that's really 5.5 hours. I did that for 20 years, didn't seem to notice any negative effects. But when I sold the business and had more time to sleep, I noticed I slept 8 hours. And now, I guess if I didn't get 8 hours, if I got, what was that, 5.5, um, I'd be cranky. But I did it for 20 years.
Yeah. Well, when I was in graduate school doing research, I had to get into the laboratory by about 5 o'clock in the morning every day, 365 days out of the year, and start testing my animals. So you just do what you got to do.
I guess we're both into some kind of mild sleep deprivation.
Yep.
I guess I was, because I got to the office by 10 after 5.
Can you make up sleep? Like if you get like 10 hours one night and like 5 hours another night, is that a thing?
Well, you typically should sleep about the same length every night. But again, some people naturally sleep for a shorter length of time, others a longer time. If you are sleep deprived, like for 2 or 3 or 4 nights in a row, and you then are not sleep deprived the next night, you will sleep a longer time than normal. You won't make up all the time you lost, but you make up enough that you typically are not tired after that one long night of sleep.
And does that help your brain kind of recover from the lack of sleep too, the cognitive?
It helps somewhat. It's better not to be deprived of that sleep. But yes, it does help.
But typically, it's my understanding you can't, like, sleep 4 hours a night, 5 nights a week, and then sleep 8 hours 2 nights a week and have it totally make up for it.
That's correct. It
Okay.
doesn't totally make up for it. It makes up somewhat for it.
So it's more of a short-term thing. If you miss one night and you get a good night's sleep the next night, you're
You're
close.
as good as you're going to get.
Right. Whereas if you continually deprive yourself of sleep by working or something, you're not going to make it all up on the weekends sleeping in.
That's correct.
Okay.
Does the position you sleeping in affect anything?
I'm sorry, does what?
The
Position.
position.
Sleep position?
Yeah.
I don't think so. Now, I wear a CPAP every night, so I have to sleep on my back every night.
Couldn't do
Now,
it even with a CPAP.
if
Well,
you
I had a
now if you have sleep apnea, sleeping on your side will often help you sleep better, help prevent the apnea.
When I was pregnant on bed rest, I was told to always be on my left side.
Well, that will prevent the apnea. In fact, one treatment that's sometimes tried for people with sleep apnea is like put a tennis ball under their nightshirt or something, a nightgown, so you can't get on your back. You might try to roll over on your back, and you encounter that tennis ball, so you stay on your side. And if you're on your side, you're far less likely to stop breathing. You with sleep apnea, you stop breathing because your throat collapses, and it's not going to do so as readily if you're on your side.
Dr. Hetzler, a question for you.
Yes.
Are you familiar with Fitbits and their sleep reporting?
Mm.
Sorry, I didn't quite understand the question.
Are you familiar with Fitbits and their sleep reporting?
Like, is it accurate? I think is that what you're,
Yes.
okay, yeah.
That you, oh, by the way, if you're on Medicare, which I am now, you have to, and you have sleep apnea, you do have to take a sleep study, and Medicare has to score it, or they won't pay for your CPAP machine, which can cost like $10,000.
Oh,
So that's why I had to take, well, I don't think, I had one before my stroke because my doctor thought I had sleep apnea. And then after my stroke, I had one because I had obstructive sleep apnea before my stroke, but I had to check to see if I had central sleep apnea afterwards. In central sleep apnea, the brain stops telling you to breathe while you're asleep. It's still treated with a CPAP, but it's a more expensive CPAP and it's more difficult to deal with.
I finally gave up. I had mild obstructive sleep apnea, and then the CPAP, like 5 AHI, which is borderline to not even treating it. But when they put me on a CPAP, I had 40 events per hour of central sleep apnea. I finally figured it out, and the respiratory therapist that helped me figure it out said that's interesting because I have a couple of other clients that are in the same boat as you, and she checked with them, and all of them had strokes. So that's interesting. So I followed it to a BiPAP machine, which also gave me central sleep apnea, and then my sleep doctor, who was a neurologist, I intentionally sought out a neurologist instead of a pulmonologist because I thought that knowing about the brain might help. And she basically said, we're pumping your uh, body so full of oxygen with these machines that it's telling your brain to shut off. And so I had some other kind of machine, an ASV machine, but I opted at that point not to take either, was it fourth or fifth sleep study, and keep going down that rabbit hole because in the very beginning she had said, you're at 5.2, you could walk away right now. But I thought I should check it out. As for the Fitbits and Apple Watches, I can talk to that a little bit. I have an Apple Watch, and so does my daughter. She has a sleep app, and she swears by it. She lives by it. I can't swear that it's accurate, but I can tell you that she feels like it is. I've thought about installing it on my watch, but I'm typically I typically sleep 8 hours a night, and I can sleep 9 if I go to bed earlier. And I don't really have any trouble getting to sleep or going back to sleep. And sometimes I'll sleep 4 or 5 hours like a rock from the time I lay my head down till the first time I get up. And so I guess I feel like I'm getting pretty good sleep. To the point that if I take a nap, it's very disruptive to me. I get, particularly if it's more than a short period of time, I get very disoriented. I wake up groggy like you do sometimes in the morning, but I can't shake it. And I feel groggy for a couple hours, and it messes with my sleep again that night in the sense I can't, I don't, if I sleep 2 or 3 hours in a nap, it's going to come out of my sleep that night. So You know, I can go to bed at a normal time like 10 or 11, but I'm going to wake up at 4 o'clock in the morning typically and not be able to go back to sleep. So I don't nap much. I don't nap ever, hardly, unless I'm sick or something, which I rarely am.
I never nap.
You
Never.
what?
I do not nap at all.
Yeah,
myself.
I typically don't, never really have. They've always kind of disoriented me. When I had my business, I'd go in the tape library because you could shut the door and be pitch black. Sometimes after lunch, I just lay flat on my back for 10 minutes in the pitch black dark, but I didn't typically go to sleep. I just got away from everybody and everything for a couple of minutes. But if I nap, I'm pretty much worthless after the nap. So, anyway, as far as who was that asking? Was that you,
Ralph?
Polly, asking about the Fitbit?
Yes, that was me.
I couldn't see you at the time. My daughter swears by hers, and you know, she was showing me all this stuff and saying, oh, there was some overall measurement that I guess it was the amount of real deep sleep she got that if it wasn't good, if it wasn't fairly high or at some level she determined was good for her based on when she felt well versus when felt like she hadn't got enough sleep. So, but she has an app that's didn't come with a phone, and I haven't downloaded one or checked it. I guess because basically I feel like I'm getting good sleep. What's been your experience with the Fitbit sleep app?
Well, I was just looking at different sleep, and mine, an average over 30 days, says I have a higher percentage of REM and deep sleep than women my age, and a lower percentage of light sleep and awake periods over a period of 30 days.
Sounds good to me.
Yeah, I don't have any sort of smartwatch, but my wife has a Fitbit, and she loves it because it shows how much time she spends in deep sleep versus REM sleep, and it's that deep sleep, that slow wave sleep, that's the restorative one. That's the one that cleans your brain and so on. So it's important to get as much deep sleep as you can. Now, the Apple Watch, as I understand it, tells you if you're awake or asleep, but does not differentiate between sleep stages. And the Fitbit, I imagine, depending on the model you have, will tell you the sleep stages, and that's what's important to know.
I think that's
It gives you a graph of the times. So you can see that graph you had about the sleep stages. It
Yeah.
gives you that graph for every night, but it's only based on heart rate.
huh. Well, that may be why my daughter downloaded an app because I believe she's getting REM and deep sleep measurements. She's getting all kinds of measurements. So a lot of cases with the smartwatches, there are, well, like comes with a stepping program, but every time you go to check your steps, there's 5 other apps that you can download if you want something more robust or different. I've been happy. I mean, to me, a step's a step. So if it counts them, that's all I need. So it's interesting that your wife put some stock and believes in the Fitbit data. Obviously,
Yeah.
it must be consistent to give her that kind of feeling. Okay, well, anybody else got any other questions?
I have something I'd like to share with you, and Dr. Hetzler may be interested after this meeting is over.
Okay,
Okay.
well, um, it's easy enough to end this meeting, and anybody who wants to stick around is more than welcome to. So,
I want to ask one other question.
oh, sure.
Before my stroke, I could usually pretty easily distinguish between dreams and wakefulness. In other words, I could usually tell when I was in a dream versus being awake. Since my stroke, I've had a hard time distinguishing between wakefulness and dreaming states. My neurologist has even had me tested on EEG looking for seizures. She didn't find any indication of that. Have you found ever other people that have a problem with distinguishing between dreaming states and waking states?
I can't say I have. Now there are there's a phenomenon called, I think, hypnagogic hallucinations. They occur during the transition between sleep and wakefulness, and you can't tell if you are awake or asleep. Now, I'm not really that familiar with that literature, but that sounds like what you're talking about.
One morning, I even tried to go to work before I realized they wouldn't want me there.
I don't have that problem. When the people stop chasing me or stop wandering around lost trying to find everybody else in the group that I'm missing from, then I know that I've stopped dreaming and I'm about to wake up. But it doesn't sound like a lot of fun because we kind of like to know what reality is, don't we?
Yes, we do. It's very disorienting.
I would think so. All right. Does anybody have anything else? Otherwise, I'll close it out. And those who want to stick around can.
I missed the first bit, but when you first go off to sleep, I always think I'm in deep sleep. The first bit, is that true or?
What exactly was your question?
Well, when I go off to sleep, I usually get about 3 or 4 hours. What I think is deep sleep. It's before I wake up to go to the bathroom. Is that true? That most of your first bit of sleep is fairly deep.
You get your deep sleep early in the night. That's that first stage 4 and so on. So that's going to typically be gone by the time you have to get up to go to the bathroom.
Right.
Yeah. So that's, again, the restorative sleep that occurs early in the night in the first 2 hours or so.
Right.
So, Chris, I would say that feeling's valid. His typical night chart only showed level 4, the deepest sleep, sometime half an hour, 45 minutes after you went to sleep and lasting for some period of time. Of course, the longer the better, because that's when the brain's doing its little cleansing thing. So I think that you're feeling that you get your deepest sleep after you first go to sleep is correct. How long it exactly lasts, you can only tell by sleep tests or measuring. So
Okay. Thanks.
it's interesting, those sleep tests, because they told me that my feet move every 5 seconds. That would be 12 times a minute. That would be thousands of times during a night. As I lay there trying to go to sleep after they wired me up, I was aware that my feet were perfectly still. So it's, who knows what you do when you're asleep. They watch you with the cameras. They hook up things to your toes, your sides of your eyes. They track your eyes with another camera. It's interesting to say the least.
Oh.
And not very
Must be hard
restful.
to, must be hard to sleep normal.
Yeah, it is pretty hard to sleep normal. And as for sleeping on your left side, there's some thought, medical thought that uh, when you sleep on your left side, you have the best alignment of your heart and lungs and other organs, as opposed to sleeping on your right.
That's what I've heard.
They'll tell a lot of stroke survivors, myself included, I think maybe Polly, I sleep on my affected side, and they'll general thought is that that's a good thing. I started it because it kept my leg from jumping around it so much at night. When I was on the top, I was free to jump around. When I was laying on my left side, I kind of was pinned down. Now, it doesn't jump around much anymore. Occasionally it will. It was pretty disquieting in the beginning. It would, in fact, interfere with sleep. So that's a whole nother can of worms, like restless leg, and which I found got worse post-stroke, and spasticity, because they all tend to interrupt sleep. Paul, you have issues with spasticity when you sleep?
Well, you wouldn't during REM sleep because you're paralyzed.
Right.
Upon occasion.
Upon occasion. So actually, it sounds like, you get pretty good sleep, and it's actually a kind of a relief from you during your 24-hour cycle.
Well, yes and no.
Okay.
The medications I'm taking do relieve, but I wake to spasms, and it wakes me when they wear off.
Okay.
So about 6 hours is all I can do.
I found some of the, I was having trouble sleeping in the rehab hospital, and they gave me Ambien. That would put you to sleep for about 4 or 5 hours, and then you could not go back to sleep no matter what you did the rest of the night. I've heard that from a number of other people. Not that I'm trying to pick on any particular type of drug, but like Dr. Hetzler said, and is still on the screen, cognitive behavioral therapy, if you can find it and it works for you, would be the way to go before taking pills. So, anybody got anything else?
Nope.
All right, well, we'll close this out, and thank you yet again, Dr. Hetzler, for another good presentation, and I'll get this up on YouTube tomorrow, so the people that couldn't be here can tune in and benefit from it. So thank you again.
Well, thank you, Ralph. It's my pleasure.
Thank you.